Endoscopic mucosal resection, EMR, for early-stage gastrointestinal tumors is potentially curative. However, this endoscopic technique is inadequate for en bloc resection of lesions 20 millimeters or greater in size because incomplete removal and local recurrence can occasionally be associated with the piecemeal EMR. Endoscopic submucosal dissection, ESD, which has been developed in Japan, enables direct submucosal dissection so that early-stage gastrointestinal tumors can be removed with a high en bloc resection rate. This enhances the potential of curative resection with accurate histological assessment despite large tumor size, presence of severe scarring, or location in a difficult position. Initially used for gastric tumors, ESD has subsequently been applied to colorectal epithelial neoplastic lesions. However, colorectal ESD, CRESD, is a technically challenging and demanding procedure because the lumen of the colorectum is relatively small, tortuous, and angulated. In addition, the colorectal wall is thinner compared to the stomach, so underestimation of the depth of the submucosal layer can result in a higher risk for perforation during the dissection phase of the submucosal layer. Consequently, a longer procedure time is required. For adaptation and continued development of skills for this procedure, considerable expert guidance and hands-on experience is necessary for optimal performance and success. However, a suitable high-level training environment has not been established as yet. Taking these factors into consideration, appropriate training in a well-recognized established program and sufficient opportunities to improve technical skills in a clinical setting are essential for endoscopists. To improve the quality of CRESD outcomes in training, it is crucial that factors predicting the level of procedural difficulty are evaluated. However, to date, there has been no prospective analysis of predictors of the technical difficulty, safety, efficacy, and limitations of CRESD. Previously, several investigators had reported indications for CRESD. However, their analyses were primarily based on clinopathological features of colorectal lesions. The aim of this study was to prospectively assess the risk factors associated with technical difficulty in CRESD. Background and study aims. Because of technical difficulty, colorectal endoscopic submucosal dissection, CRESD, is not widely performed. The authors aim to determine risk factors for such technical difficulty as defined by long procedure duration, greater than or equal to 150 minutes, perforation, and piecemeal resection. Patients and methods. Patients with consecutive colorectal tumors treated with ESD between April 2006 and December 2010 were enrolled in a prospective cohort study. For prediction of technical difficulty, 3 types of factors were investigated: tumor location, tumor type, and colonoscopy related. Cases were subsequently categorized into earlier and later periods: April 2006 through August 2008, 123 lesions; September 2008 through December 2010, 124 lesions. Variables were analyzed using multiple logistic regression with subgroup analyses for each period. Results: 247 lesions were analyzed. Flexure location was an independent risk factor for technical difficulty as measured by longer procedure duration, odds ratio OR 4.1, 95% confidence interval, 95% CI 1.1 through 14.9, piecemeal resection 4.7, 1.1 through 17.2, or perforation 8.8, 1.1 through 56.8. Tumor with scarring or locally recurrent was a risk factor for longer procedure duration, 4.7, 1.7 through 13.7, and for piecemeal resection, 7.8, 2.2 through 25.0. Tumor of size greater than or equal to 50 millimeters or spreading across greater or equal to 2 folds was the strongest independent risk factor for longer duration, 6.3. 2.8 through 15.4, and was an independent risk factor for longer duration in both time periods, earlier 3.3, 1.1 through 10.4, later 27.4, 7.4 through 138. Flexure location was an independent risk factor for perforation, 13.9, 1.5 through 129.1, and for piecemeal resection, 5.1, 0.9 through 25.2 in the earlier but not the later period. Conclusions. Factors predicting technical difficulty of CR-ESDs were clarified. Their importance was influenced by the increasing experience of the endoscopist.